Welcome to Vision 2020 USA's Spotlight Series. Today's topic is Analyzing National Surveillance Survey Data and Current Research on Vision Impairment. Featuring Matt Robich, a biostatistician with the College of Optometry at The Ohio State University. The Spotlight Series is hosted by Dr. Rajiv Ramchandran, an associate professor at the Flom Eye Institute at the University of Rochester, and Dr. Dean Van Asdale, an associate professor at the Ohio State University College of Optometry, leading members of the Vision 2020 USA Executive Committee.
Thank you for joining our Vision 2020 meeting for August. In brief introduction, Matt's a biostatistician working at the Data Coordination and Analysis Center for the College of Optometry at the Ohio State University. He has a master's of public health and biostatistics and specializes in analyzing national and state surveillance data, particularly the Behavioral Risk Factor Surveillance System survey from the CDC. And it's a pleasure to have both Matt here as well as Dina on the call, because they've been working together on trying to use some of the surveillance system data that exists both nationally and also statewide to help to push some state agenda items on vision care in Ohio. So with that, I want to turn it over to Matt and to carry us through a discussion on what they're doing there in Ohio.
Great. Thank you so much for the introduction. I'm going to pull up my presentation now. Can you see that all right?
Yeah, perfect. Great.
All right, great. Okay, so I'm Matt Robich, and I'm part of the Data Coordination and Analysis Center at, or the DCAC at Ohio State University College of Optometry. My presentation today is on analyzing national surveillance survey data and current research on vision impairment. So first, I'd like to acknowledge Vision 2020 for having me, Dean Van Asdale for heading a lot of the current research I'm going over today, Lisa Jordan for leading the DCAC, as well as John Cruz, NACDD, PBO, and Nebraska BRFSS. Okay, so quick overview. First, we'll start with some general research goals and background vision health information, then go over the national surveillance surveys with vision health questions, go over some considerations, limitations, and advantages of working with national survey data, with an emphasis on the behavioral risk factor surveillance system, and give an idea of what kind of research can be done. My plan is to start with national surveillance surveys, move to examples with state data, and then end it with local level data. I will go into how we use national surveillance survey data to research important health questions and how to utilize state-specific data from these national surveys, and then end with research that is community-specific. It's just some overview of vision impairment in the United States. Approximately 6 million Americans have vision loss and 1 million have blindness. These numbers will vary widely depending on where you get your estimate or which survey you look at. This variation is important to note, and I'm going to go into more detail later on about it. So we rely on national surveillance surveys to give population estimates of vision impairment, which can then be used to implement programs and policy. So it's important these vision impairment questions within these surveys are accurate and validated. I'm sorry, I think I'm on the wrong page here. I'm sorry, can I stop sharing for 1 second? Something's going on with my presentation where it's off by a page, and I wouldn't want to be talking about the wrong stuff. So let me just go all the way back real quick, just so I have this right. Sorry, buddy.
Oh, that's okay. So just to make a couple of announcements, we are meeting up at GOES with folks at the IAPB and the 14th. And so Jeff Todd is leading that. He's our national representative our North American representative for the International Agency for Prevention of Blindness. So it will be a meeting on those who are members of the IAPB, and Vision 2020 is one of those. So hope to have some updates with that afterwards.
Thank you so much. Sorry, I just needed a second, and
Perfect.
we're back on it. Thank you.
Great.
So we rely on these national surveillance surveys to give us population estimates of vision impairment, which can then be used to implement programs and policies. So it's important these vision impairment questions within these surveys are accurate and validated. So in children, early severe impairment can attribute to delayed motor, language, emotional, social, and cognitive development with lifelong consequences. In adults, vision impairment can severely impact quality of life. They can experience lower rates of employment and higher rates of chronic conditions, depression, and anxiety. In older adults, vision impairment contributes to social isolation, difficulty walking, a higher chance of falls and fractures, and a greater likelihood of entering a nursing or care home early. So by 2050, the CDC estimates without effective interventions, diabetic retinopathy will increase by 72%, cataracts will increase by 87%, glaucoma will double, age-related macular degeneration will double, vision impairment and blindness will increase by 150%, and the cost will increase 157% to $373 billion. The CDC's health initiative recommends a distinct public health approach to address vision through 3 key activities: assessment, application, and action. So assessment involves surveillance and epidemiology, application involves applying public health research, and action involves integrating vision health into programs and policy. So step 1 of that would be assessment, surveillance, and epidemiology. Step 1 is to better understand and plan for vision care needs. There's a critical need to assess the burden of vision loss, quality of life, comorbidities, prevalence estimates, and to monitor trends using state and national data. Evaluate quality of life, comorbidities, prevalence estimates, and to monitor trends in persons with vision impairment. We need to assess the role of available data sources for measuring, monitoring vision loss and eye disease. And so some questions that go along with assessment or assessment. Questions we asked: what is the impact of vision impairment across the lifespan? Which populations are most at risk for vision loss? How do we improve the case definition of vision loss? And how do we increase access and use of vision care services? Understanding how many people are affected by vision loss and eye conditions, who they are, and where they live is key to developing policy and allocating resources to improve vision and eye health across the nation. The next step is to use the knowledge gained from national surveillance surveys to conduct applied public health research at the national, state, and community level. Understand the consequences and costs involved with vision loss and develop evidence-based research and interventions to address this issue. Using research, we can evaluate access and vision care services. Later, I'll present our current research, and one study evaluates just that using Medicaid data in Ohio. We can also research the impact of vision loss, how it has on health, health behaviors, comorbidities, and labor market production. So we are assessing vision impairment and applying research to quantify need for vision services, which can then go on to influence policy. So that leaves me to the last step: action, programs, and policies. The end goal is to guide programs and policies to promote healthy lifestyles, as well as prevent disease and chronic conditions, including vision impairment. Public health programs can encourage beneficial provider and patient behaviors and remove barriers to access. Programs and policies can increase awareness of vision health disorders, prevent unnecessary vision loss, and improve the lives of people with vision loss. To get action, we must conduct evidence-based research. So here are some of the publicly available national health surveillance data sets. Out of them, I'll be mostly focused on the BRFSS today, but there are several other national surveillance mechanisms with questions that regard vision. They include the American Community Survey, National Survey of Children's Health, National Health Interview Survey, the National Health and Nutrition Examination, and the Vision and Eye Health Surveillance System. So starting with BRFSS, it is a national surveillance random digit dialing telephone survey that collects data on US residents, their health-related risk behaviors, chronic health conditions, and the use of preventative services. They interview more than 400,000 adults 18 years or older every year, making it the largest continuously conducted health survey system in the world. They conduct they collect data in all 50 states, the District of Columbia, and 3 US territories. Data is at the national, state, and local level. One question asked in the core module is on the vision impairment. I'm going to be talking about this a lot throughout the presentation, and the question reads, are you blind or have serious difficulty seeing even when wearing glasses? And the response options are yes, no, don't know, not sure, or refused. So here are some other national surveys with vision questions. The vision question that BRFSS uses, it came from the American Community Survey, or ACS, which is a household survey on demographic, social, economic, and housing characteristics of the US population. It's given by the United States Census. It does not include other health questions other than there's 6 Department of Health and Human Services standard disability questions. They're on blindness, deafness, serious difficulty concentrating, remembering or making decisions, serious difficulty walking or climbing stairs, difficulty dressing or bathing, or difficulty doing errands alone. Data is collected via internet, mail, telephone, and in-person interviews. The National Survey of Children's Health collects data on children 18 years or younger, includes physical and mental health, access to quality and healthcare, and the child's family, neighborhood, school, and social context. It's funded by the Health Resources and Services Administration and Maternity Child Health Bureau. They collect national and state level data and is mail and web-based since 2016. Data on vision loss in children is pretty scarce, and research from this survey could help strengthen these estimates. The National Health Interview Survey is an in-person interview that collects household data on a broad range of topics and is conducted by the National Center for Health Statistics, a center of the CDC. It samples 1 adult and 1 child in the household, and this survey does not have state data. The National Health and Nutrition Examination Survey, or NHANES, no longer asks vision questions since 2008, but it's unique because it combined interviews with physical examinations. So that's why I wanted to bring it up. The Vision and Eye Health Surveillance System from the CDC uses data from multiple surveys to generate composite estimates of the prevalence of vision loss, eye disease, and vision care services. This can be used as a tool to quickly extract national and state level data on age-related macular degeneration, cataracts, diabetic retinopathy, glaucoma, other eye disorders, vision care, and vision problems and blindness. This data can be further stratified by year, age group, gender, and race and ethnicity. So a real quick example on how to use the VEHSS to get national prevalence estimates. This one's going to be, just my example is for self-report vision loss using BRFSS from 2017. So first you would select the condition from the options at the top of the page, and you can see I selected the options in green to get self-report blindness. And then on the next page, you select on the left-hand screen, and the VEHSS will provide a prevalence estimate for your choices. And then this gives a nice map of the US prevalence estimates and then by state. So before we go into any current research, I would like to go over several things to consider while using national survey data and limitations we're working with. I see this as the foundation on which useful survey studies are built, and without them, we could have biased data and make incorrect inferences. At the end of the presentation, I compiled resources for BRFSS data for this. So in order to get reliable estimates from the entire population, national surveys use weighting. Unweighted data represents the actual responses and each respondent before any adjustment is made for the variation in the respondent's probability of selection, disproportionate selection of subgroups relative to the state's population distribution, or non-response. If we deviate too far from these assumptions, the results can be affected. Weighting each record appropriately adjusts for these assumptions. Weighting is necessary to make generalizations from the sample to populations. Common weighting software would be SAS Survey Procedures, Sedan, SPSS, Stata, and R. So checking the sample size. Small sample sizes are less informative than larger ones, may produce unstable estimates, and inferences are made less useful. The sample may not be sufficiently powered to detect legitimate differences between groups, causing a false negative and type 2 error. One way to check if the sample size is too small is to look at the variance. BRFSS previously followed a rule of not reporting or interpreting percentages based upon a denominator of fewer than 50 respondents in the unweighted sample, or did not report a half-width of a 95% confidence interval that was greater than 10. In 2011, they've replaced this with relative standard error. That would be the standard error divided by the mean, and then that's multiplied by 100 to get a percentage. A survey with lower RSE has a more precise measurement because there's less variability around the mean. They do not report percentages where the RSE is greater than 30% or the denominator represents less than 50 people from the unweighted sample. So that's how the BRFSS handles it, but you can handle it in different ways. A simpler method that I like is reporting confidence intervals whenever possible. This gives the reader an idea of how variable the estimates are without suppressing any information. It's a way to accurately give the information, then let the readers come to their own conclusions of the strength of the estimates. Is the sample size too small? There are options to use multiple years of data if available, avoid small subgroups, and combining response options when appropriate. So if the sample size is too small, it may be beneficial to use multiple years of data. Small sample sizes are common when researching state or local data, doing subgroup analysis, or if your question is not asking the entire sample. Please note that an additional weighting step needs to be taken in order to appropriately adjust for each year's sample size. One concept that's easy to overlook is variable selection when using multiple years of data. It's common for surveys to update questions and responses. Therefore, it is important to check the variables you're using to ask and make sure they ask the same question and have the same set of responses every year you plan to use. If the questions or response options differ between years, it may become impossible to make direct comparisons. And then the last consideration is missing data. Missing data is when an observation has no value assigned to it. Different types are missing completely at random, which would be the missing value is not related to any of the variables of interest. The probability of being missing is the same for all cases. Missing at random is data is missing systematically related to the observed, but not the unobserved data. And for those two types, the missing data has nothing to do with the value itself, and so it's less likely to impact inferences. And then missing not at random is when data is systematically missing. Missing data is systematically related to the unobserved data, and this is considered non-ignorable. It's missing informative data, and steps must be taken to mitigate the impact of it. So some common approaches would be deletion or imputation. Deletion is simply a respondent is dropped when they have a missing variable for any variable in the study. Pairwise deletion keeps respondents with some missing data, excludes respondents for the variable with the missing response, but keeps the respondent for analysis with non-missing variables. Dropping variables is when a variable with many missing responses is dropped instead of excluding any respondents. And then another option would be imputation. A single imputation is missing data is filled with a single plausible value, such as the mean. And then multiple imputation relies on regression models to predict the missingness in the missing values. It incorporates uncertainty through an iterative approach. So now that we've gone over what should be considered, now for the advantages of working with national surveillance data. Some basic benefits would be that there are a large number of respondents, a wide variety of variables, And the larger the sample size, the more accurate the estimates, providing smaller margins of error. Since data is self-report, it's relatively inexpensive as well as quickly and easily obtained, which makes surveying large populations possible. The database is already collected, so that's one major step we don't have to worry about. For most of the data, it's collected every year, so you can observe trends over time, as well as combine years to increase your sample size further when conditions you're working with are relatively rare or you're looking into smaller subgroups. For BRFSS and other national surveillance surveys, data is collected for each state, and county level data is available as well. State and local data can give important information on community needs. Another advantage is we're able to create population estimates of vision impairment and vision care services. The estimates from these surveys can drive program and policy. Then after they're implemented, it's also possible to compare estimates before and after implementation to see if there are noticeable changes in the population. Okay, so limitations. Almost all national surveys use cross-sectional data. This means that each subject is only studied at one point in time. Therefore, we cannot establish any temporality between vision impairment and anything we study. We don't know if vision impairment came first, or if the outcome we were studying came first, or if they occurred around the same time. This also means we cannot make any statements on causality. It would be inappropriate to say vision impairment causes anything we are studying based on this survey data alone. Self-reporting is a test, measure, or survey that relies on individuals' own reporting of their symptoms, beliefs, or attitudes. Survey data is self-report. The negatives are that people can be biased when reporting their own experiences. So as long as the subject's memory is reliable, questions like chronic health conditions should be reliable. A question like, has a doctor, nurse, or other health professional ever told you had a stroke is straightforward. The vision impairment question in BRFS, again, it's, are you blind or have serious difficulty seeing, even when wearing glasses? And it sounds straightforward, but estimates will vary depending on the survey. It can differ even more when the question is worded differently. The CDC states, surveys based on self-reported information may be less accurate than those based on physical measurements. For example, respondents are known to underreport body weight and risky health behaviors, such as alcohol intake and smoking. This type of potential bias arises when conducting both telephone and face-to-face interviews and when interpreting self-reported data. Data should take into consideration the potential for underreporting. And then different surveys ask different questions about vision impairment. This issue was shown in the paper, The Variability of Vision Loss Assessment in Federally Sponsored Surveys, Seeking Conceptual Clarity and Comparability, from 2012, where John Cruz et al. Identified nearly 100 vision measures from 12 different national population-based surveys in the US. This shows there's no consistent measure of vision or vision impairment. There's limited comparability of data and a lack of conceptual clarity to characterize the population of people who are experiencing vision impairment, and as a consequence, vision surveillance is limited. So now I'd like to discuss work that we've recently done on how we use survey data and what kind of research can be done and that needs to be expanded upon. This will include assessing comparability in complementary national vision health surveillance items in Nebraska BRFSS, vision care utilization and insurance coverage prior to and following Medicaid expansion in Ohio, and then the Prevent Blindness Ohio and NACDD project that's been ongoing. So before I get to that, real quick, I would like to go over BRFSS's Visual Impairment and Access to Eye Care module. Since 2013, BRFSS has asked the question on vision impairment with the yes or no binary responses. But before this, there were 11 questions on vision impairment and access to eye care included in the BRFSS survey from 2006 to 2011. And then it was also brought back in Nebraska in 2017 and 2018. These were asked only to participants 40 years old or older. Some of the relevant questions that we'll be talking about as we go through the presentation would be a question assessing scaled distance visual function, which is how much difficulty, if any, do you have in recognizing a friend across the street? Second scaled visual function question on near vision. How much difficulty, if any, do you have in reading print in newspapers, magazines, recipes, menus, or numbers on the telephone? They were also asked about eye care utilization. When was the last time you had your eyes examined by an eye care doctor or by a doctor or eye care provider? Those who responded with more than a year were asked a follow-up question regarding the reason for not having vision care services. And it was, what is the main reason you have not visited an eye care professional in the past 12 months? Respondents were also asked one question regarding insurance coverage. Do you have any kind of health insurance coverage for your eye? So I brought up the previous slide because in the first study I'm presenting, we will compare responses from those questions to the binary vision impairment question. This study is on assessing comparability in complementary national vision health surveillance items. Here we have the chance to see how two separate vision measures compare in participants who answered both in the same survey and an example of how to use state-specific data within a national survey. The goal was to assess comparability of the binary and the scaled vision questions used in the BRFSS. We wanted to check the robustness of the binary vision question and the potential it has to capture or exclude people with varying levels of vision impairment using questions from the vision module. The rationale. In 2011, BRFSS removed vision module, and the binary vision question that came from ACS was not asked until 2013. So when Nebraska added these scaled vision question modules back in 2017 and 2018, there was a rare opportunity to compare the responses of these vision impairment questions. And then just a note, since BRFSS survey uses the same visual function or the same visual impairment question that was developed by the ACS, I'll be using the term ACS and BRFSS binary question interchangeably throughout this presentation, but they're going to be talking about the same question. So here are the visual impairment questions we'll be comparing. The ACS question asked in the BRFSS core model, again, are you blind or have serious difficulty seeing even when wearing glasses? And then the distance and near questions, they're prefaced with, I would like to ask you a question about how much difficulty, if any, you have in doing certain activities. If you usually wear glasses or contact lenses, please rate your ability to do them while wearing glasses or contact lenses. Again, that's important because the ACS question also mentions when you're wearing glasses or contact lenses. And so the distance activity question, one more time, was how much difficulty, if any, do you have in recognizing a friend across the street? The near question was how much difficulty, if any, do you have in reading print in newspapers, magazines, recipes, menus, or numbers on the telephone? These two questions had the same scaled response options. They were no difficulty, a little difficulty, moderate difficulty, extreme difficulty, unable to do because of eyesight, unable for other reasons, not sure, don't know, or not applicable blind, or you can refuse the question. So getting a sample size was straightforward here. This analysis included respondents from 2017 and 2018 BRFSS Nebraska survey who answered all three binary, distance, and near questions. This included 20,484 participants. .7% of participants answered the binary ACS question that they had serious difficulty seeing even when wearing glasses, and 95.5% did not. For the distance question, 85.4% said they had no difficulty, 9.8 said they had a little, 3.3 had moderate, 0.5 extreme, 0.7 not because of eyesight, 0.4 not for other reasons, and that would mean in total 4.5% answered moderate difficulty or worse. For the near question, 63.9% had no difficulty, 23.1 had a little, 9.8 had moderate, 2.1 had extreme difficulty, 0.7 could not because of eyesight, 0.3 could not for other reasons, and 2 respondents said not applicable blind. This means 12.7% answered moderate difficulty or worse. A larger percentage of respondents showed trouble with near vision than distance vision. So in order to visually compare both BRFSS visual function questions to the binary question, a summary measure with 4 response categories was created. That would be no difficulty in the first column. It means the participant responded no difficulty to both the near and distance question. Little difficulty would be the participants responded a little difficulty to one or both of the questions. Moderate difficulty, participants responded moderate difficulty to either question. And then extreme difficulty is participants who responded extreme difficulty, unable because of eyesight, or not applicable blind to either question. So these results are going to be shown for the full sample 40 and older, and then by age group, which would be grouped into 40 to 65 or 40 to 64 and 65 plus. This table displays the percent of respondents in each visual function category out of those who responded yes to serious difficulty seeing, and then the next row is those who said no to serious difficulty seeing. So the top 2 rows are for the full sample size. And some important highlights here are out of those who are blind or have serious difficulty seeing, 16.8% responded with no difficulty at distance and at near. Out of those who did not have serious difficulty seeing, 8.7% said they had moderate difficulty for at least near or distance, and 1.2% had extreme difficulty with near, distance, or both. Using a combination of visual function responses, we can use them to predict the binary ACS response. The area under the curve, ROC curve, is an aggregate measure of performance across all possible classification thresholds. It ranges from 0 to 1, and an AUC of 0.5 would suggest no ability to predict the outcome, or the same as chance alone, and then 1 would suggest perfect predictability. So we found an AUC of 0.83, which is considered good generally. From the comparison table and from the ROC curve, you can see that there's some predictability between the standardized vision questions asked in the BRFSS survey, but there are a large number of respondents who answer differently based on the question and suggests a further need for validation of these vision impairment questions. Our conclusions. Scaled responses are moderately successful at predicting binary response to self-report vision impairment. Individuals reporting vision impairment with binary response may report no vision impairment at distance and near. Individuals who report no vision impairment with a binary response may still report some challenges with distance and near. And this study shows that responses to questions about vision impairment will vary depending on the way the question's asked. This highlights why it is so difficult to create an accurate estimate of vision impairment in the United States and the need for a systematic approach to surveillance. So here's another example of what you can do with state data from surveillance surveys. Here are infographics we made for the CDC in 2024 that showcase the impact of vision impairment, and one was made for each state. This is for Ohio. These are still waiting for CDC's clearance, but the CDC has published similar figures we created previously. And so for this presentation, I just wanted to give the most up-to-date information. From the prevalence map, you can see for each county, you can see vision impairment prevalence ranges from 1.1 to 3.6%. This shows these disparities are geographic in nature, and there is a need to look further into the communities with the highest risk. Just some other stats from the poster. There are more than 250,000 people with vision loss in Ohio. Total cost is estimated to be $4.9 billion per year. 28% of people with severe vision impairment report diabetes, while 12% of people without vision impairment report diabetes. 50% of people with vision impairment report arthritis, while 30% without report arthritis. For mobility issues, it's 51% with and 13% without vision impairment. 52% of individuals age 65 and older with severe vision impairment reported having a fall within the past year. And then 21% have hearing loss compared to 6% without severe vision impairment. And then out of those who report poor health, 13% report severe vision impairment compared to the 4% who report severe vision impairment out of those for people who report good health. And then out of those who did not finish high school, 13% report severe vision impairment compared to 6% of those who did graduate high school. And then we could also see that acuity loss is most prevalent in those 85 plus, and that there are more women than men with acuity loss. So next, I would like to go over the manuscript Vision Care Utilization and Insurance Coverage Prior to and Following Medicaid Expansion in Ohio. This was published in August 2022 in the Ohio Journal of Public Health. It's an example of applying public health research to check the results of policy change in the population. It also showcases the impact advocacy can make on national surveillance data collection. The study tested utilization of vision care services before and after Medicaid expansion in Ohio using 2005 to 2011 data and then 2018 and 2019 data from the BRFSS vision module data. The rationale behind this paper is to better understand vision care utilization patterns and access to care. So some brief information on the Medicaid expansion in Ohio. The expansion of Medicaid in 2014 increased coverage for eye care services. Ohio Medicaid benefits include one exam and one pair of eyeglasses every 12 months for individuals younger than 21 years and adults over 60 years. Sorry, one exam and one pair of eyeglasses every 12 months for those younger than 21 and over 60. And then one exam and one pair of eyeglasses every 24 months for all other adults. Coverage includes glaucoma screenings, contact lenses without prior authorization, with prior authorization, and medical and surgical services when medically necessary. Copays for services include $2 per refractive exam and $1 per dispensing eyeglasses. So as I mentioned earlier, the CDC supported additional vision-oriented questions between 2005 and 2011 for any state that elected to include the model. And to better understand the trajectory of vision health in the state of Ohio, a collaborative group of stakeholders, including the Ohio State University, the Ohio Department of Aging, and the Ohio affiliate of Prevent Blindness, successfully advocated for items from the vision module to be reintroduced into the BRFSS as state-added questions in 2018 and 2019. The goal of this was to assess any change that may have taken place as a result of advocacy efforts and policy change, including the implementation of the Affordable Care Act. So 3 state vision exam questions were examined in this study. These are the same 3 as the optional questions from the vision module I mentioned earlier. The first was on eye care utilization and was, when was the last time you had your eyes examined by any doctor or eye care provider? Responses were within the past month, within the past year, within 2 years, or 2 or more years ago. Those who responded with greater than 1 year were asked the follow-up question regarding the reason for not accessing vision care services. What is the main reason you have not visited an eye care professional in the past 12 months? Responses included cost or vision, do not know or have an eye doctor, cannot get to the office or clinic, cannot get an appointment, no reason to go, have not thought of it, other, don't know, not applicable, blind, or refused. And then respondents were also asked one question regarding insurance coverage. Do you have any health insurance coverage for eye care? Responses were yes, no, don't know, or not applicable, blind, or refused. For the sample size, respondents were included if they responded to all 5 demographic questions, were at least 40 years or older, and did not respond to any of the vision module questions with not applicable, blind. Respondents were not included if they answered all 3 vision questions with don't know, not sure, refused, had missing options, or were not asked these questions. This totaled 1,600 respondents that were excluded from both administration periods. And then this resulted in 22,265 respondents between 05 and 11, and then 7,588 between 2018 and 2019. Moving on to the results. This table is displaying the demographics of the respondents in 2005-2011 compared to 2018-2019 in the right column. There was some variability between age groups, between time periods, but other than that, the demographics remain relatively stable. This table displays the overall and by demographic percentage of individuals who visited an eye care professional in the previous year for each time period. The overall percentage non-significantly increased from 60.7 in the first time period to 64.3 in 2019. This is a 3.6% increase, but it was not significantly statistically significant. When stratified by income, we see a slightly larger increase in those who report an annual household income of less than 15,000, going from 54.7 to 61.9. And the cohort with the largest percentage of individuals who visited an eye care professional in the previous year were the over 65-year-old cohort. Smallest percentage was 40 to 49. This table displays the percentage of respondents who did not visit an eye care professional in the past 12 months due to cost insurance or had no reason to go for the overall group and by demographics for each time period. In Ohio, the primary reason for not seeing an eye care provider in the past 12 months was no reason to go in both 2005, 2011, and 2019. The second most common reason for not seeing an eye care provider in the past 12 months was cost or insurance. When you compare cost insurance to all other responses, the percent of participants who responded with cost or insurance statistically significantly decreased between 2005 and 2011 to 2018-2019, with a p-value of less than 0.001. From 2005 to 2011, 26% of the respondents responded with cost insurance, which went down to 20.6, which is a 5.4% decrease. Like the previous table, you can see this decrease most prominently in the less than 15,000 group. Cost or insurance was the primary reason for 55.5% of respondents in the first time period and 31.5% in the later period, which is a 24% decrease. Also, the primary reason for the $15,000 to $25,000 cohort, the primary reason for that cohort changed in 2019 to cost/insurance to no reason to go. This indicates a potential shift in the affordability of vision care services in these specific cohorts. The other demographic cohort that had substantially larger estimated decrease than the overall group was in those who did not graduate high school, where cost or insurance was the primary reason for 39% of the respondents in the first time period, and then 29.5% in 2019, which is a 9.5% decrease. And then the last table we'll look at displays the overall and by demographic percentage of individuals who have any kind of health insurance for eye care for each time period. Insurance coverage for eye care increased between the first time period and the second significantly, with a p-value less than 0.001. And in 2005 to 2011, the percentage of respondents with eye care insurance was 60.2. This increased to 70.7% in the later time period. This is a 10.5% increase. Important differences They were found within demographic stratification as well here. While the overall increase was 10.5%, the increase for those making less than 15,000 per year was 27.8%, and the increase in the did not graduate high school group was 17.9%. So conclusions from this paper. The percentage of those receiving eye care services remained relatively stable in Ohio, despite efforts by advocates actively promoting greater vision care access. The primary reason for not obtaining care from an eye care professional in the past 12 months remained relatively stable for the full cohort, but cost or insurance as a barrier decreased, and insurance coverage that included eye care increased in those time periods. These findings underscore a complex interaction between insurance coverage, vision care access, and utilization, as well as provide insight into aspects of vision health that we need to prioritize. In both time periods, the most common cited reason for not seeing an eye care professional was no reason to go. This finding is consistent with reports from other states implementing the vision care module and is particularly troubling given the asymptomatic nature of most common sight-threatening diseases. Early detection and effective management can significantly reduce vision loss in diseases such as glaucoma and diabetic eye disease. Stratification by demographic characteristics using data provides important information on those seeking eye care and the frequency of eye care visits. It is encouraging that the oldest cohort reported the highest rates of vision care in the previous 12 months, as that age group is at the highest risk for vision loss and comorbidities. We found lower examination rates in lower cohorts, indicating further work is needed to identify barriers resulting in this disparity. Those reporting the lowest rate of eye care provider visits in the 2005 to 2011 time period were those with incomes less than 15,000, but also had the largest increase in visits, had the largest decrease in cost insurance as a barrier, and the largest increase in insurance coverage between time periods. This is important because previous studies indicate preventable vision impairment is correlated with lower socioeconomic status. This does lead to more questions. Why do we see an increase in coverage, but not a statistically significant increase in care? It is clear more needs to be done to fix this unmet need, and working within these communities with the highest risk can help provide an answer to this question. So our goal is to take a systematic approach to how we do surveillance. And as we move into local data, this ability to compare with national data becomes even more important. To have any way to compare with national prevalence estimates, community surveys need to ask the same questions as national surveys, because as I've shown, participants may respond differently based on the wording of the question. While national and state data answer important questions, community-specific studies can give actionable insight into local community needs. Projections for vision impairment are getting worse, so now is the time to look at communities at the highest risk of vision impairment and evaluate needs, create programs, influence policy, and create change at the local level. This leads me to a study partnered with Prevent Blindness Ohio and NACDD. One advantage of a study like this is you can measure refractive error and get an objective measure of vision along with vision impairment survey questions, all in one study. In this study, we surveyed vision and measured refractive error in 573 participants aged 18 or older across 3 regions in Ohio. This includes Cleveland, which would be in Northeast Ohio, Columbus representing Central Ohio, and Portsmouth representing Southern Ohio. Focusing on these 3 regions provides diversity in age, race, poverty, and urban or rural characteristics of the population. The goal was to estimate prevalence of measured and self-report vision impairment, as well as quantify other health-related outcomes and identify barriers to care in areas of high prevalence vision impairment. Those identified as visually impaired or at risk for vision impairment were asked to participate in a secondary survey and a qualitative interview. Those who lack an eye care provider were provided with educational materials. Individuals below the 200% of the federal poverty level with or at risk of vision impairment receive vouchers for comprehensive exams and eye care. And then PBO followed up after 1 month after the initial screening to assess care utilization and barriers to care. These surveys were done at Walmart. The proximity to residents and the large number of daily customers ensured adequate traffic to be able to reach these 573 participants. The sample is 18 years or older, but 80% of Walmart's customer base is over the age of 40. So that allowed us to oversample populations that were at the greatest risk of vision impairment. PBO utilized their evidence-based nationally certified guidelines for screening assessments, including distance acuity, near acuity, and visual field testing using the Optic 5000 instruments and autorefraction using SureSight instruments. The ACS binary vision question, the BRFSS scale distance and vision distance and vision questions, and then other common survey questions on vision health were asked here. Questions from the Ohio Medicaid Assessment Survey helped assess unmet needs for vision care services. And this unique combination of questions has never been asked in the same survey and provides insight into the connection between health determinants, vision impairment, and poor health outcomes. So results, 51 participants, which is 8.9% of the 573 reported difficulty seeing. This is considered 2 to 3 times the prevalence of the CDC estimates. Those reporting difficulty seeing had worse mean distance in the better eye logMAR visual acuity of 0.28 plus or minus 0.24 versus 0.15 plus or minus 0.17. That p-value was significant at less than 0.001. Half of the individuals reporting visual difficulty, or around half of the individuals reporting visual difficulty, had a better eye visual acuity better than 20/40. And then 9.8% of individuals who reported no visual difficulty had distance visual acuity of 20/40 or worse. This is in line with the Nebraska study, displaying that the same subjects can show differing levels of vision impairment depending on the method of vision assessment. The most commonly cited barriers to access to care among those with vision impairment were cost at 19%, lack of spectacle wear at 16%, and then transportation or getting to the doctor at 12%. This study emphasizes the need for surveillance within high-risk communities that goes beyond national surveillance. So to conclude, vision impairment is an important issue and prevalence is increasing over time. National, state, and local survey data each provide unique and valuable information about vision health. There's a need for conceptual clarity among vision-related questions asked in national surveys to accurately estimate vision needs, and future research needs to keep this in mind. And then there are a limited number of groups working with this kind of data, and there's a critical need for more research and more researchers to rigorously study vision surveillance data. So here are some of the BRFSS resources that I mentioned earlier, and thank you for your time.
That's great. Thank you, Matt, for that very thorough take and to see how we're using surveillance data and apply it to real life examples. Are there any quick questions out there? I know that was a lot of information. I think Kira has a comment there in the chat. I hope you get to read it. They're talking about Ann Haynes will have vision this year, so that's one thing they're going to be putting in. And then Prevent Blindness has a site here on advocacy that they're working on. They have, I know, supporting a bill out there on early vision assessment for children. So definitely take a look at what she's saying. Of course, you know probably hers from Ohio and in Prevent Blindness and leading the public health group out of Prevent Blindness. So, any other
Yeah,
quick questions? So how does your group work there in Ohio? I know you do a lot of the statistics and all this compilation, which is a great asset and great tool. And how do you interface with the other folks who are sort of asking the questions or coming up with the questions, or do you all work together on that?
so um, basically, I do the analysis as part of the DCAC. Lisa Jordan runs the Data Coordination and Analysis Center. So we have a website where we take requests. So if anybody needs data analysis, basically you can go to the DCAC website and request an analysis. And so we have a lot of work we get within the College of Optometry. And I think that's where I connect with Dean Van Nasdale here, where he brings a lot of the work that we do to us.
That's great. So you have sort of some primary investigators who are interested in these questions, and you kind of give the supporting help to kind of compile, and you're very knowledgeable about the surveys from all the work that you've done on them. So that's great. And Kira also points out that the government is going to planning on cutting the amount of money that there will be for the national surveillance system. Vision is included in many areas in national surveillance. Any ideas in the group or Matt, you too, about what can a group like Vision 2020 USA do in terms of helping to voice this concern?
Yeah, I don't have any answers myself, but I think that's a great question. I think there is always more we should be doing.
I think one of the things
Definitely.
too is that I think more people need to be looking at the data and using the data. I think if you can demonstrate the fact that the data, a lot of the data are being collected, not a lot of people are using the data. Part of that is because there's a capacity issue. We don't have very many people like Matt who can pull and weight the data appropriately and make sense of it. And so I think if people aren't using the data, then I think that there's a sense that all of the resources put into that data collection aren't being used necessarily effectively. So if we can demonstrate that we're using the data, I think that makes a big difference too for policymakers. At least that's been our experience, at least here in Ohio.
That's good. So, Dean, do you engage with policymakers at the state level on a routine basis, a regular basis, and talking about vision?
We do a little bit. It's tricky in academia here. We can't do too much to sort of promote different policies, but if we could put data together and give it to policymakers and say, here, look, this is the prevalence, these are the comorbidities that go along with it, these are the other health outcomes based on the health surveillance data that we get, using stuff that's both national and state specific, looking at the Ohio Medicaid Assessment Survey. It tends to be helpful if you can quantify it and do it from a relatively objective way. I think it's helpful. The other thing that's been good for us is that people who are not in the vision community but are interested in policy or are faculty in other departments that are more health administration oriented, when they've seen some of our stuff, that sort of piqued their interest too, and they take that stuff and sort of amplify that message. So I think if you can sort of find different outlets for that, I think it turns out to be really helpful.
And I think you brought up a great point, is making the case for vision and having non-vision people really help to promote that, to see how it, applies to their area and their sphere, which is very important because we all live in our own echo chambers, and it's important to get out of that and to really push to see how vision is a very unifying function, because it's a very basic function and very necessary function for quality of life, and I think that's really key. Great. Well, great talk and great presentation. This has a lot of relevance, especially what's going on now nationally. We don't know what the CDC is going to do about vision. They're getting rid of their chronic disease division here. We'll know more in October once this year's budget ends. So I'm sure you may have more information in your own areas, but we'll see how this goes. On the 15th of August, we're going to have our GOES summit that is helped to be chaired by the various academic centers, which is a Global Ophthalmology Summit. So Vision 2020 helping to put up a little symposium there, a presentation of 6 speakers, and Dean was going to be part of that. So that's going to be great, talking about advocacy in the United States. And also Jeff Todd will be there as well. So I will look forward to reporting on that. And our next meeting, Vision 2020, which will be on the 15th of September, 3 to 4 p.m. Eastern. And we'll have Susan Primo and some of her colleagues coming and talking about access to vision care and what they're doing in that regard. In fact, I'm actually headed off to the Association of Clinicians for the Underserved, which has a vision care or vision interest group. I'm going to be presenting something tomorrow there, and it's another exciting group that has a lot of people interested in vision. So I'm happy to share that information when I come back and talk to you more in September. Thanks all for joining.
Thank you, everybody.
Thanks
Have
for
a good
having
one.
me.
Take care.